It is now my distinct pleasure to call the City of Philadelphia and its behavioral health care leadership to the stage for our last panel of the day. The fine doctors from Philadelphia, here they come. Come on out. Wonderful to see you all. Dr. Pritchett, thank you. I'm going to relinquish moderator to you. Thank you.
Thank you. Good afternoon, everyone. My name is Dr. Tierra Pritchett. I'm the Deputy Commissioner of the Philadelphia Department of Behavioral Health and Intellectual Disability Services. I oversee the Administration, Finance, and Quality Division. We are pleased to be here with my esteemed panel of participants. It's not very often that we get out all together, all at the same time. I am here with Dr. Wright, our Deputy Commissioner. He oversees the Behavioral Health Justice Division, and we are here with Dr. Shoyinka. He is our Chief Medical Officer. So we are going to give you a little bit of information about the behavioral health crisis system in Philadelphia and talk to you a little bit about a couple of clarifying questions, and then we're going to have a little bit of dialogue with the audience. So we have a presentation, and I'm going to pass it over to Dr. Shoyinka.
Thank you.
Thank you.
Good afternoon. I'm Sosunmolu Shoyinka. I'm the Chief Medical Officer for the Philadelphia Department of Behavioral Health. And it's a pleasure to be here with you all this afternoon. I'll be walking you through the work that Philadelphia has done over the last about 3 years in preparation for 988, and then since the go-live of 988. And then, as Dr. Pritchett said, we will get into a discussion about some of the practicalities of the implementation. Next slide. How do I change? I need a little bit of help.
Yep.
Oh, thank you.
You made magic happen.
Magic. All right, so I think first of all, to ground the conversation and provide a framework, it's helpful to understand the vision, the organizing framework for DBHIDS. And it's summarized in the acronym TECH. TECH standing for Addressing Trauma, Achieving Equity, and Engaging Community. Now, when you think about, I'll tell you a very quick story, and then we'll get into then to sort of help illustrate what this means. Now, existing systems, oftentimes, particularly legacy systems, can be developed in such a way that they either don't mitigate trauma or they actually add trauma. So an example would be one story of a 10-year-old in our system, this actually happened, who already had a history of trauma and turned up in his treatment program expressing suicidal ideation. And because of the way our system had functioned up till that point, the only recourse to transport him to the next highest level of care, which is a crisis center, was to put him in cuffs. And so the program director called the police because the parent was not available to do the transport, and this poor kid ended up in cuffs in the back of a car. That is an example of adding trauma. I'm pleased to say, obviously, we haven't stayed there, and we'll talk about how we've transformed the system. But it's really the intent is to alleviate trauma, mitigate trauma, so that sort of thing doesn't happen. Next slide. All right, thank you. So as I said, our transformation efforts really began in 2017 with the transformation of the children's crisis continuum. And that served as a template for the work that's been done on the adult side, but it's a lot of work. So in 2019, our team did a survey of national best practices. We went as far as Worcester, Massachusetts, and other jurisdictions around the country, and basically sifted out what seemed to be promising or actual best practices and put that together in a framework. In 2020, that framework was finalized and then continued to flesh it out with other meetings across the country. We also did something that I thought was an idea that was taken really from the business literature, which is we did a process map. We looked at flow of individuals in each of our 5 CRCs, Adult Crisis Response Centers. So we actually mapped it out how much time it would take for a person and looked at additive processes that were not helpful, and so on. And unfortunately, in 2020, we experienced the very tragic shooting of Walter Wallace, which I would say really shone a spotlight on the gaps in our crisis system and really kicked all of this into high gear. In 2021, we continued our study by looking at technology platforms, of which there are several excellent ones in the country, some commercial, some developed, homegrown, if you will. And we also received, I would say, tremendous support from the City Council, as well as from the state financially. Put out an RFI in March of 2021, and then an RFP later in the year. Eventually ended up awarding those RFP for mobile crisis services. One key piece of our infrastructure that I really want to underscore is the learning collaborative. Now, as you might understand, we have, in any system that's got such a multiplicity of actors, it's hard to, one of the necessary pieces is to get everybody to agree on what success looks like. And so the Learning Collaborative was pulled together with participants. We'll come to exactly who was present in just a few slides, but mobile teams, crisis centers, advocates, people with lived experience, and so on. And that group has met sometimes bi-monthly, sometimes monthly now for 15 months, and that has been very effective in helping us to define success and agree on what best practices look like. Part of that effort has also been an innovation challenge for those participants to look at what they're doing and then come up with better ways to do it. And all of that has been captured digitally. And this year, our efforts obviously have continued with implementing the mobile teams. I will come to those in just a minute, and continued procurements. Next slide. So Philadelphia was honored to be recognized as a model city for 988 implementation. We were selected to host the launch of 988 on July the 15th of 2022. And what we noticed, consistent with what is seen in other jurisdictions, was an immediate spike in calls to that crisis line. 988, obviously, Philadelphia has other lines, but that particular line saw a spike of almost 40%. Now, it since has dwindled back to about 21%, but it's never returned to the baseline. Some of that's not all due to 988. Some of that was due to just the very intentional pushing out of this information in the aftermath of the death of Walter Wallace, as well as during COVID, where there was such distress. Next slide. This is a slide that is busy. It's got a lot on it, but essentially what it is a formula that allows call centers to calculate projected call volume and then work backwards to what adequate staffing would be. And so we did this actually in 2019, preceding the current efforts. And using these calculations, we've actually built our crisis call center staffing to double what it was in 2019. Next slide. All right. So I think most people here know this, but it bears repetition. Contrasting 988, what is made accessible through 988 and what is available through 911. So 911 is essentially a relay station. The call takers receive the calls, they decide who needs to go out as a police, fire, EMS, and they dispatch. There is not much interaction beyond that. 988, particularly the Philadelphia framework of doing 988, sees the contact as the primary intervention. So over the last several years, our teams have been trained to fidelity in the Lifeline framework. And so if you look at national data, 80% of calls get resolved on the, from that initial contact, and we are pretty much there as well. So the crisis counselors take the calls, they attempt to resolve the calls, the crisis while the person is on the call. That does not always happen. Sometimes there's a need for what's called active rescue, where somebody is actually in danger at that point, and so they will activate, the systems that exist, 911 essentially. But for the most part, it's either a resolution or a dispatch of the mobile teams. Next slide. Now, 988 is the gateway, it's the front door to a whole suite of additional crisis-related services. So I'll talk about the 911 call triage. Essentially now, Philadelphia, with under the leadership of Dr. Wright and his team, our team, we now have, and I think we may be, as far as I know, the only system in the country that's doing this right now. Certainly in the Commonwealth, we now have 988 counselors physically present in the call room. That's a testament to a lot of hard work by Dr. Wright and his team, and a lot of collaboration from our law enforcement partners. We can talk more about that during the Q&A. Talked about expanding the staffing of the call center, the call center staff, and their training to Lifeline standards. We've also expanded our mobile capacity from 2 teams to 4 teams. I'll talk about that in a bit more detail. And are adding a 5th crisis response center. So in Philadelphia, the crisis response centers are a network that are strategically, geographically placed around the cities to ease access so people don't have to travel very far. We did lose one at the beginning of COVID, but have since re-procured that. It's due to go up and actually go live in the spring of next year. An additional intervention, structural intervention in Philadelphia has been looking at behavioral health urgent care. So this is based off of the framework or the model, the urgent care model on the physical health side. Conceptually, the idea is that providing access before people get into crisis, so it's somewhere where they can just walk into, talk to somebody, get a med refill, and so on, should head off a more severe crisis downstream. And also, and again, Dr. Wright and his team have worked closely with our law enforcement partners to stand up co-responder teams. Next slide. So this is more detail on what I was sharing earlier. We have now 4 teams, 4 providers, that is 4 agencies that are that have implemented between them 15 to 20 teams, and now we have 24/7 coverage all around the city, every region. The 2 existing providers are GFK, which has been in the system for many, many years, and Consortium. The new ones are Elwyn and Path. And I want to call your attention to the team configuration, because this is, again, different than what you find in most jurisdictions. In Philadelphia, we made the decision to staff our team with 3 different types of personnel. So the first is a behavioral health trained clinician, then also a peer specialist or a family advocate, and this came directly from working with our family advocate network all the way through. And then we also added a medical professional. Now, the idea behind having a medical professional is that oftentimes behavioral health is divorced from medical issues, which we know that doesn't happen. The head is, after all, connected to the rest of the body. So we felt that it would be helpful to have the ability to respond to a full spectrum of need, including withdrawals, injuries, and so on, at least immediately. And these teams are tasked with assessing. They're not just there to make a binary decision, okay, you're sick, you're so sick you need to go to the CRC. No. The teams are tasked with engaging the individual, understanding the context of the crisis, if possible, de-escalating the individual and resolving the crisis if possible, and we'll look at data in a little bit. And then in addition to the mental health crisis, we know that social determinants drive a lot of crises, and so they're also trained to engage that, or engage individuals around that. So the goal is resolution, not just an assessment. Next slide. So I mentioned regionalization earlier. This is, again, one of the innovations of the Philadelphia model. This is based on historical dispatch data. So we know that obviously, historically, dispatch to arrival times for mobile teens varied pretty widely, particularly during COVID, where there was such disruption in the system. So part of the idea behind the regionalization is to cut down on that transit time. You can think about traffic and so on and so forth. But the other idea is really to foster a deeper tie between the mobile team agencies and the communities that they serve. So Philadelphia is a city of neighborhoods, like many other cities. And what the needs of Northwest Philadelphia are very different from the needs of North Philadelphia or Northeast Philadelphia or South Philadelphia. And so the idea behind this is to create opportunities when they're not responding to crises. The mobile team agencies have been tasked with developing the kinds of relationships that will encourage the neighborhood to come to them. So it's not somebody from outside your neighborhood, it's a friend who you know and trust. Next slide. And I mentioned the Learning Collaborative. I'm not going to read through all of this, but I want to call your attention to the second and third bullets, which are really strengthening relationships. It's far easier to call somebody who you've met in a forum like this, where you've had a discussion, than somebody who you've never met, and that's the basic idea. And also to standardize expectations. Next slide. Lots of training also happened in those fora. Next slide. And I did promise that we would share a list of the collaborative participants. We had families, we had persons with lived experience, we had grassroots advocacy organizations, we had substance abuse providers, we had the mobile team agencies themselves, facilitators, and special needs agencies. Next slide. Now, I mentioned earlier that one of the keys to success is being very clear about what success looks like, right? It's understanding, it's far easier to hit a bullseye if you have a bullseye. And so we spent a lot of time defining success early on. And so consistent with that tech framework that I mentioned earlier, the entire crisis transformation, but particularly this mobile crisis implementation piece, is intended to, first of all, reduce law enforcement involvement. So we want to deflect people right from the beginning, reduce involuntary commitments, because there's actual data that they can be harmful, exceedingly harmful, not just to the individual and their relationships, but psychologically injurious to the individual. And then also we want to the extent possible, reduce a reliance on higher intensity services like inpatient crisis response centers. On the flip side, we'd like to increase crisis resolution. And again, we're starting to see signals of success in this arena, increasing warm handoffs so that people are actually not just getting advice, well, you should call your crisis center, but actually being helped to connect to their crisis center. And then increase satisfaction. And again, we will show data that shows shows signals that we're actually beginning to accomplish those goals. Next slide. Now I'll turn this over to Dr. Wright to walk us through the next several slides, and then I'll come back to walk us through the data.
Thank you.
Thank you.
Good evening. How's everyone? Excellent, excellent. Can you hear me okay? Fabulous. Thank you, Dr. Shoyinka. As he mentioned, in addition to being the Deputy Commissioner for the Department of Behavioral Health, I also have the honor of being the Director for the Behavioral Health and Justice Division. And so what I'm going to share with you in terms of the collaboration internally with Dr. Shoyinka and his team, and also externally with our justice partners and our law enforcement, is that piece that falls under behavioral health and justice. right? And that's so key. So what you're looking at now, the crisis continuum and the goal and what we were trying to do. Dr. Shoyinka mentioned earlier about relationships, and you know how important that is, especially when you're working cross systems. And so when you look at what's on the screen in terms of person in crisis and the Philadelphia crisis line, how we move through that, and you look at what our goal is, you can't do this without having relationships, right? Both internally and externally. And so when you think about the co-responder team, that was so important. We all understand that with the behavioral health crisis, that you do not want police showing up for a behavioral health crisis. They have other things that they need to do. They're protecting and serving. You want people that are experts in behavioral health showing up for behavioral health crisis. Makes sense, right? But here's the thing. Even though we have 988 and we worked very hard to get that going, and even though we have these relationships, people still called 911. And it's interesting, during the pandemic when we were really going through some of this with some of the community and getting their feedback, we actually presented in front of City Council. And I remember distinctly a grandmother who listened to what we said about all this wonderful work we're doing, the collaborations, and she said, yeah, thank you so much for sharing. I don't care what number you give me. When I call 911, somebody better answer. And so we took that into consideration. And what she was saying is there shouldn't be any wrong door, right? And it took me 50 years to learn 911. She was, of course, exaggerating on purpose. But her point was, now you're giving me a new number. And so what we had to do was meet people where they were. We definitely want to get the behavioral health calls to 988, and that's happening, as Dr. Shoyinka has mentioned. But we also had to consider the fact that there are some people who may be slower to moving over to 988. And what do you do in that situation? Well, you need to enhance what you're doing in 911. And so the CERT, the co-responder teams, is really important because it gave us an opportunity to still be able to address individuals that may call that number, even though they have a behavioral health crisis and they didn't call 988. There shouldn't be a wrong door. We should still be able to get them where they need to go. Next slide. And so when you think about how we set this up, the crisis intervention response team and the overview, the police officers that we were working with were already trained in crisis intervention. So we have a long-standing relationship with Philadelphia Police dating back to 2007 for that particular training, crisis intervention training. So that was very important that those officers were the first ones that were involved in that collaboration. The other thing is we needed to adjust the script, right? What is the script that the call takers will use when people call in? And so you have several options. You have the option of having someone be directed to police. You have the option of someone being directed to fire, EMS, and you have the option of someone being directed to behavioral health. So even though they didn't call 988, they called 911, we can still get them to the PCL. And that's the most important thing here, to really give that grandmother what she was telling us, which is, I don't care what number you give me, get me where I need to go. And so listening to the community is very, very important. And so as community members and clinicians were, hey, we don't really want a police response. We want a community-only response. We listened to that and said, you have a good point, but what do we do about individuals who are still continuing to use 911? This is our answer, that co-response. And so it is not the preference for individuals who have a behavioral health challenge, but if you call that number, we can still get you to PCL. We can still get you to the resources. And so when you think about three things, primary components, this is really important for you to know, to enhance the identification and triaging of behavioral health related calls. What we did was we sat down with the call takers, the dispatchers, Philadelphia Police, and our clinicians, and all the individuals that we mentioned before, and asked how can we create a script that is not too cumbersome, right? Because things are happening in real time, right? How do we identify the best route for the call to go? And so we had individuals working on a script for probably better than 6 months to really hone in on what are the important elements so that the person receiving the calls, they have a lot on their plate. They don't need to be thinking about what to say and how to say it and how to direct. There also is the challenge of having individuals that may be calling in. Is it the individual in crisis? Is it a family member of the individual in crisis? Is it a neighbor observing a certain situation? It's the neighbor calling. And so depending on who's making the call, what kind of information are they going to be able to give you? And that is a concern. And so making sure that the script that the call takers were using was such that whoever called, whether it was the person in crisis, a family member, an observer, a neighbor, that we could still get the information and ascertain where we needed to go. The second thing is to improve dispatch of the range of responder types. And so when you see this, this is a continuum of what is possible, as Dr. Shoyinka had pointed out. And then lastly, development of the CIRT, the mental health professional paired with the CIT trained officer. This is important. We have clinicians riding in cars with police officers, unmarked car. The police officer is not wearing the usual uniform that you would see normally. The clinician riding with the police officer, they have on the same t-shirt or the same uniform. And so you're showing up not with lights blaring, not with sirens going. You're showing up, and as Dr. Shoyinka mentioned, if we've done it correctly, then you're probably going to recognize somebody in the community. Why? Because we're using providers that are working with the police officers. And so that's the expanded or enhanced version that we're going to get to probably in 2023. We're going to be able to have that same regionalization that happens on the crisis side. We're also going to have that on the search side. Next slide. And so there are several pathways to access a crisis intervention response team, starting with direct dispatch, which I just described. You call in, the call taker triages the call, directs it to the proper place. The second place is the patrol support. And so we may have individuals who are responding to calls that are already out in the field, right? And then they may say, hey, this looks like a behavioral health kind of call, based on what I'm seeing here. Let me call my CERT partners, okay, and get them in. And so they would come in and take over that case. And then, of course, another one is the officers actually listening to the radio and hearing some of the things that are going on in the community, and they can then dispatch themselves, so to speak. Does that make sense? All right, next slide. And so this is the piece that I think, Dr. Shoyinka, we were really, really proud of, and that is the intense work that it took to get Philadelphia Crisis Line staff embedded in the 911 call center. I mean, think about that for a moment, how unique that is, right? To have individuals, clinicians, trained clinicians that are working in the space with call takers and dispatchers. That took a lot of work, it took a lot of patience, understanding different priorities, different challenges, different agendas. Everyone wanting the same thing, which is safety for Philadelphians. But how do you get there? How do you understand the difference between what fire EMT or EMS are doing compared to law enforcement, compared to a behavioral health specialist? Those were the challenges. And so as part of this capacity building, we really had to pilot. And so that's part of this, I guess, a little more than a year that we had to really see how do we get individuals who are not dispatch, who are not call takers, to be able to listen in on the calls with the individuals so they can ascertain what it is that I can best do to help. And so that was a major, major focus. And so I'm not going to read all this to you. You can look at this. This is for you to take back. Just kind of gives you an idea of what it took. But it really took a lot of collaboration and patience, speaking different languages to some degree, right? And understanding what it is that we need to do to come together to get to the end goal, which is safety and support for Philadelphians. Next slide. And so I will turn it back over to our good doctor here. And we can go into more detail as to how we did this when we get to our question and answer period. Thank you.
Thank you. Thank you, Dr. Wright. So in the interest of time, I'm just going to walk us through this data very quickly. If you keep in mind the earlier comments about how success is defined, we're reducing certain things and we're wanting to increase certain things. So this illustrates where we're at this point in time. So next slide, please. So I mentioned this earlier that we did see this spike in call volume right after on the weekend of July the 16th. It was almost 40%. Now that has dropped back, but not to where we were in 2019. So we've had an overall increase in call volume of about 21%. That is good news, because that suggests that those are calls that are not going to 911, and they're coming rather to the behavioral health system. Next slide. This is a overall, so we've received 58,000 calls overall in total since the January 2022. Call transfers from 911 at 500 and over 500. What I want to point out with respect to that is this is not a full picture of all the calls that are coming to behavioral health. So we have, for example, calls to Dr. Wright's point that are being transferred to our call takers who are right now in the call center, in the 911 call center. That's not coming over to the 988 line, so to speak. Our other metrics are consistent with national standards. Call speed to answer is 14 seconds. The national benchmark is 20 seconds. And we have stayed consistently right about that since well before July. Average call time, now this is a call duration. This is a proxy for the level of intervention, to the extent to which the caller has been engaged and what tools are being deployed during that interaction. It's about 8 minutes, which is pretty up significantly from our baseline, which was about 2 minutes back in 2019. Next slide. So that's huge kudos to our team. Next slide. All right, so this is a count of our dispatches, and 2022, we're well over 7,000 dispatches. And what I want to call your attention to is the heat map. You can see that Southwest Philadelphia has the highest number of dispatches in the city. But you can also see that it's broken out by adult dispatches and children's mobile team dispatches. This is good because this is a proxy for how, first of all, that the idea is taking hold in the community, that you can actually request a mobile team, you can be responded to by behavioral health personnel rather than law enforcement. Next slide. And this is one of the this speaks to one of the comments that we made earlier. Again, one of our goals is to ensure that to the extent possible, crises are being resolved in the community. So you can see that the most frequent result of a mobile team engagement is people stay in the community. They're stable in the community, which is exactly what we want. We still have a significant number of emergency involuntary commitments. That is when the team feels the person is, the crisis is severe enough that they actually need to be brought to a safe space for further evaluation and stabilization. But you can see also that if you look back at January, that's 21 people required, or 21 episodes resulted in a person saying, okay, I know I'm not doing well and I want to go to the CRC. Now that's up to 71. Now that's good because, again, keep in mind that is a person who's not being traumatized by being placed under involuntary commitment and transported in the back of a police vehicle. Next slide. We were very happy to see this, the results of evaluation. So we have a consumer satisfaction survey team here in Philadelphia that basically gives us feedback about how well our services are doing. And this was very good to see. Over 70% of service recipients, a sample of about 70 people, but over 70% of those individuals had a good experience. This is heartwarming because it means that those services are person-centered and that it's meeting people where they are. Next slide. And thank you. We will now switch to Q&A, and I will turn it over to you, Dr. Pritchett. Thank you very much.
So in the interest of time, I know you guys are going to be moving to the aisles to ask some questions, so I'll kick it off with an initial question, which is, we've had and seen the survey of satisfaction, but what does success look like? We've heard us talk about the Philadelphia model, the Philadelphia way. We've heard us talk about relationships. Do you think that we have been successful in our implementation efforts, and what do you think that we need in order to continue to move forward?
I would say that we are seeing signals of success around the metrics that we selected for ourselves as a system. I would say, consumers. Now, keep in mind, these are people. If I just go back to that very last data point, the satisfaction of people who receive the services. Keep in mind that these are people who are maybe experiencing the worst day of their lives, and are saying, yes, these services alleviated my distress. They met me where I was. They were delivered in a way that I found satisfactory. And also, this was not shown on the data slides, but we also have other slides that actually show that the numbers of people experiencing 302s or involuntary commitments are going down. So on a number of measures, we've seen as well, again, it's not in this slide deck, but we've also seen our dispatch times begin to trend in the direction that we wanted. They were much higher, but they're now down to just a little over an hour. We're still working on that. So from my perspective, I would say we are heading in the direction that we wanted to.
And I would only add that in terms of the crisis interventions response teams, what we've seen is less than 2% of those individuals that have been engaged by their team actually have an arrest. And so the vast majority of individuals that are engaged by the CERT team actually fall into the category of taking somebody in for an involuntary commit or voluntary commit. But the arrest doesn't happen when the CERT team shows up. And so that's important. So even though someone may have called 911 and they wanted to call 988, or it was purely behavioral health, and a police officer and a clinician show up, they don't go to jail, right? It's either resolved on the spot, or the individual volunteers to go in for further testing or assessment, or if it's something where it's really in the person's best interest or health to be involuntary committed, that team of clinician and police officer will take that individual to a CRC and not to jail.
Thank you.
Hi, thank you for your presentation. My name is Chessie Tronchoni-Bello. I work with, I'm a mental health clinician at La Puerta Abierta. We're a small nonprofit in North Philadelphia serving the immigrant community. And my question is, what considerations have been taken regarding funding and implementation to make sure that people who are uninsured and uninsurable have access to services that are culturally responsive in their main language? Examples is like, what is the call time for people in their main language if they need interpretation services? What would be the steps for those like warm handoffs for people who don't have access to health insurance to make sure that they get the treatment that they need at the crisis moment, but also after? Thank you.
That's a lot of questions.
Yeah, I was going to say, she packed her questions really well.
So I'll defer to you on the financing question, but with respect to culturally sensitive interventions, our teams have received a good amount of training in that regard, and as you may be aware, Philadelphia has implemented across the board language access for people that for whom English is a secondary language. We certainly are welcome, feedback on how that is going. But in general, I have not heard any concerns that people are not receiving services in the language that meets their needs.
And to piggyback on some of that, we take at our office, we have a diversity, equity, and inclusion committee. And so we look at what's in our system across the board and how do we make sure that we are providing culturally competent care that's a part of the treatment services, and how we're communicating and messaging that out to our providers. We're also looking at how do we do that in contracting, and we do a number of different trainings. To address your question around funding for some of those different things, we have applied for a number of different grants. We have received a number of different grants. There's a model of moving those 4 teams that you looked at to becoming billable on the managed care side. So the Medicaid billing piece, we're trying to move to ensure that they're able to get billing. So our teams internally have done a yeoman's job with working with our providers in order to ensure that we get there. Then we're also looking for the uninsured to ensure from the county perspective, how do we create funding mechanisms to ensure that those services are also hit and achieving that, hitting those communities where there's lack or underinsured individuals there. Before I go to you, sir, I do see a virtual question, Dr. Wright and Dr. Shoyinka. How do the behavioral health intervention specialists and medical professionals negotiate responsibility in mobile team calls? Do the medical professionals fall back unless there's an apparent medical issue, or are they more involved throughout?
So the teams utilize a standard practice, which is triaging. You know, they take as much information as possible when the calls come in, and then so when the dispatch is made from the PCL team to the mobile agency staff actually call that person directly and gather information, and gather as much information as is available at that time. And so based on that information, then the intervention is who goes first is dependent on that. Obviously, we know that situations evolve, and so you may start out with a situation where you think it's purely behavioral health, and then you get, you know, when the team actually arrives on site, it's obvious that there's more to it that's going on, you know, whether it's an organic delirium or, you know, withdrawal situation or something along those lines, and then obviously those decisions are taken at that time.
Yeah, and I would only add that the triage piece, that part I talked about with the script that the call taker reads to ascertain which is the right place to go, that is so very, very important. And so if it is a CERT team that is called and that is deemed necessary, then the protocol is that because there is a behavioral health and possibly a need to secure the area as well, then the police would take the lead in terms of making sure everyone is safe so the clinician can do his or her job. If it is pretty clear once you get there that it is not what we thought it was, and it really is a behavioral health focus call, then the clinician takes the lead and does that, and then the police goes and does something different. As Dr. Shoyinka indicated, it can change in real time. You may have thought you had a behavioral health only call, and you get there and something else has happened. Or you may have thought you had a situation where the area needed to be secured, and actually it turns out that's not the case. And so you have to be able to pivot in real time and have those teams available as needed as the situation changes.
Thank you, sir. And then I'll go to you, ma'am. I see you standing. Go ahead, sir.
Thank you. Rob Waters, I'm the founding editor of MindSight News, which is a nonprofit digital journalism site focused on mental health reporting exclusively. We're a Sozosei grantee, but we're also pleased that we got some funding, and we're going to be doing a collaborative project with Resolve Philly, looking at violence prevention, and mental health in Philly. So my question for you guys is, I'm wondering how we know that many cities, including Philadelphia, is kind of reeling from an epidemic of gun violence, and I'm wondering how the behavioral response units, the crisis response units, and this kind of behavioral and mental health response in Philadelphia relates to and can assist with violence prevention. How do those two worlds intersect in your view?
So I'll take a stab and then invite my colleagues to comment. Violence prevention is, as you know, an extremely complex issue, and as we know, persons with mental illness are far more likely to experience violence than they are to perpetrate violence. So I think we should start with that. The primary role that DBHIDS has played with respect to gun violence is responding to the trauma that accompanies gun violence. So over the past 2 years, our department has expanded trauma supports, primarily through a program called Network of Neighbors, that now blankets the city 24/7, and these are teams that are going to communities to support them after the event has happened. clearly, we've one of the more recently, at least one occasion, we've had a mobile crisis team in the immediate aftermath of the shooting event go to physically be present on site to provide supports for that community at that point in time. But that's what has been done by DBHIDS, and I'll turn this to my colleagues if you have any other comments.
I know you may want to say something specific about the training, but what I would say is that another important thing that Dr. Shoyinka is talking about in terms of the trauma is that we have those resources available all the time. So it's not just gun violence that is traumatic, obviously it's very much so, but the network of neighbors and other resources that we have are available regardless of what the trauma is. Okay, gun violence is a major one, obviously, that most cities are dealing with. Also, we work with the managing director's office and the mayor's office in terms of trainings in our communities and making sure that different community agencies have access to these resources and also the training, so that in terms of the prevention piece that I hear you talking about, it really is to address the trauma and the underlying issues that can lead to violence. And sometimes you have individuals who have been traumatized and end up being a shooter, and you also have people who are in both situations. And so helping people deal with the traumas that they're dealing with ahead of time before violence occurs is another avenue of what we would call that preventative piece, is making sure that people have access to training, making sure they have resources available so that they can make a different decision if they happen to be one of those individuals that are considering picking up a weapon.
I'll invite you to watch the, just to piggyback, the recent production
Oh, yes.
called Trigger. It's required watching. Yeah.
Great, thanks very much.
Thank you. See, ma'am.
Watching.
Can you hear me? Okay.
Yes.
Oh, hi. Hi. So my name is Zakia Williams. I'm the co-founder of Black Men Heal, and I also have a private practice up in Jenkintown, a therapist that provides mental health. I wish that this question was about my profession. It's really a personal question. I'm the oldest of 12 children, and my youngest brother has a diagnosis of schizophrenia. The nature of his illness is that he goes on and off of his medications. So when he's off of his medications, he's oftentimes in the city of Philadelphia. People don't know who he is, so they call the cops on him, and it turns into it escalates into a situation where he's ended up in CFCF and, all of these different things. So first of all, I want to commend you all for what you're doing. And I just want to say, with my brother being a young black male in the city of Philadelphia, when he sees a policeman, it always escalates the situation. No matter how he's feeling, it may not be that bad of an episode, but when he sees a policeman, it just always escalates the situation. So much so that he was taken to, I think it was Episcopal Hospital, and he was there for a while, and they were trying to sedate him. It couldn't, whatever happened, it didn't do as it was supposed to do, and he knocked the glasses off of a nurse, and they sent him to CFCF. He was there unmedicated for about a month. They wouldn't let us talk to him. It evolved into a situation that it didn't have to happen. So my question is there some way that we can get out to the public when you see people like my baby brother, what language to use to call 911, because like you said, and I'm sorry, I'm getting your names messed up, but the one in the middle, that sometimes they don't call 988 because they don't really know about it. They call 911. And, it just always turns into a very ugly situation that brings me and my family. We always try to get information. They won't give us any because he has to give permission. Well, when he's in that psychotic state, there's no way he can give permission for us to talk to any of the doctors or any of those things. So I do appreciate, like you said, having someone show up to him. But what is the language that I guess we should use? Because sometimes in different neighborhoods, people will call us and ask us, like, should we call the cops? Because they know who he is, and he's nothing like the way he acts when he's in an episode. So just what language, I guess, should we be using so he can go to the appropriate place instead of ending up in jail? Like now his record is extensive now, and he's just not even a criminal at all. So.
And so, Dr.
Yeah,
Wright,
I would say the
take
first
it back.
thing is that in terms of the language, what we're doing, and I know that both of you could speak to this extensively, is we're getting the information out as you have suggested so that And as you hear me talking up front about whoever's making the call, it's not always the person in crisis. It may be the neighbor. It may be a person that's observing. So they need to know that 988 is available, and that because a person may be acting in their mind bizarrely compared to what they're used to, doesn't mean you need to call police officers. And so I know we're about to have a campaign
Yes.
to get that word out there even more. We had to kind of slow roll that after July 16th, so that everybody could kind of catch up with Philadelphia. That's a shameless plug. And so we had to slow down our marketing of 988 so the rest of the country could catch up. But that is exactly what needs to happen. As neighbors, family, friends, people need to know that you don't need to call 988 in those situations, even if that individual may be behaving in a way that scares you. And I'm going to be very clear. As a clinician, I can tell you that that is often what happens. When people don't understand what they're seeing, what they're witnessing, they're afraid. And so the next thing they do is call the police officer. And the police officer would really rather do something else because they know that that is not a situation that is for them, even though that person may be behaving in a certain way. So that's the first thing is, stay tuned. We're going to really launch this thing in such a way that everyone will see. You'll be inundated with the marketing campaign. And I don't know if Joe Powell and that group is here, but yeah, okay, great.
We're going to be, you'll hear some more messaging. You'll hear us having some more smaller community groups and conversations to hear what's happening. So appreciate you reaching out to us. We also have a trauma palm card. I'll defer to Dr. Shoyinka, who may be able to provide a little bit more. This is our last question and our last little bit of comments before we wrap up.
Yeah, thank you. I think it's an excellent question, and Dr. Wright, I think you and Dr. Pritchett covered this all. I'll just add one fine point. The part of the issue is that when we use language in communicating with different communities, it's sometimes not framed or conveyed in a way that people are able to receive. So we may be sitting down here thinking, oh, we're pushing out all this information, but people are really not hearing it in the same way that we think it's being put out. So to just put a fine point on what's already been said, part of the intention behind this social marketing campaign is to gather information from communities across the city to help us understand how best to craft those messages so that people can then be made aware, not just of 988, which is crucial, but really the full spectrum of what's available to Philadelphians, oftentimes free.
So thank you guys for all of this time. I have to make sure we give our staff who make this work look so easy and make it look so good when we come up here to talk about all of these discussion points. They've done a wonderful job, and the providers that we get to absolutely work with and all of those connected to this. Melissa's going to come back with some closing remarks, but thank you guys so much for our time.